So many things you have in your stomach are going to be ulcers and then reflux. Right? Basically, esophageal sphincter top is weak, so stomach contents splash up, cause damage, or the acid inside of itself is too long, you get ulceration. Basically, we go in here in the mouth, down the esophagus, in the stomach, small intestine, which is more liquidy and full of acid and more things, breaks it down, and the large intestine, which absorbs all the fluid and pushes out the poop down here. All right, excellent. Let's talk through a few things. This here is a picture of gastrointestinal reflux disease, which is basically GERD. Basically, the esophageal sphincter is not as tight as it should be, and so the stomach acid splashes up. So when we generally treat GERD, we're not going to do anything with the actual sphincter control, right? Because it's hard for us to actually tighten up that muscle. What we do is we're going to neutralize and decrease the acid. So we're not stopping the reflux itself. We're stopping acidic reflux. Okay? And over here we have our beautiful healthy stomach with nice rugae, little ridges, and then here we have the ulcers where basically the acid has eroded the stomach lining. So I think everyone pretty much knows what GERD feels like. You probably experienced some point in life you went and had a couple ghost peppers and slammed a beer or something. I don't know what you kids do these days. But it might, bless you, it might cause you to reflux up that material, right? So it's kind of painful. It feels like right here. It's called heartburn. Nothing to do with your heart, right? It's always your stomach and your esophagus. So certain triggers can make things worse. Caffeine, spicy foods, other acidic things. Medications can affect your acid content in your stomach. So what is the problem? Well, the problem is that esophageal lining is technically designed to withstand some acid, right? But not a lot. So if the acid continues, the esophageal lining changes. It'll change its cellular shape to be able to basically withstand the acid, which is then called Barrett's esophagus. Barrett's esophagus is pre-cancerous esophageal cancer. Basically, the cells are starting to change to adapt to the environment. It is not going to be further erosion, so the cells just start to change. More erosion, cells keep changing, you have esophageal cancer. It's very hard to treat. Usually they do an esophagectomy, you take the esophagus out, stretch out your stomach, and you can't lie down for the rest of your life. You don't have any sphincters except basically a long tube goes right down to your intestine. A little tiny pouch for a stomach. Okay? It's quite an extensive surgery. And the life-altering drug. Okay, that's the patients with it. They don't seem to enjoy it, so it's either that or they are dead. So, end of strategy. Alright? So take GERD seriously, people. So the thing is, we all know, like, I used to have really bad heartburn. I actually had surgery to fix it. Now it's better. But I knew certain things, if I ate it, it's going to cause just terrible heartburn. Pepperoni pizza, you name it. Boom. I was dead. So the things you want to do is try to avoid those triggers. If I know I eat this, it's going to cause problems, I probably shouldn't eat it. Okay? It's better to eat 5 to 6 small meals of the day versus larger meals. Larger meal, what happens? Stomach expands out, full of food, full of acid. There's a lot of pressure, right? It wants to go somewhere. Where's it going to go? All right, loses distance. It's going to go upwards. It's going to reflux up into the esophagus. So high collars, what is that? Basically sitting 45 degrees. Okay. Oh, you're bad. Stop smoking, lose weight, reduce stress. Medications. If those don't work, new surgery. All right. Peptic ulcer disease. kind of the same in line with GERD, but different, right? GERD and peptidoses kind of go hand in hand a little bit. If you have GERD, you probably have a highly acidic stomach, right? So you might have those ulcerations in your stomach lining or in your small intestine. What are the telltale signs of someone having an ulcer? How will they feel? You're going to have that abdominal pain. When's it going to get worse? When they eat, right? When they eat, what happens? Stomach acid increases. Stomach acid increased. Now that ulceration is getting attacked by stomach acid even more, causing worse problems. So duodenum, that is your duodenum, and is your first part of your small intestine. Gastric ulcer is basically in your stomach lining. Stress ulcer. Basically, stress ulcer is something we treat prophylactically in the hospital if you're in the ICU. Basically, when you go through your stress response, what happens to your body? You get your metabolism increases. Metabolism increases, but stomach acid is going to increase. Increase stomach acid, increase trauma, body goes through stress, erode down your stomach lining. With ulcers, you have a high chance of having an upper GI bleed. Alright, that's what basically causes an upper GI bleed. It's going to be some sort of stomach ulcer. So we want to look for the black tarry stools or coffee ground emesis. Look for the signs of the ulcer. Okay. Chronic gastritis. This is going to lead to something called pernicious anemia. Basically, your stomach lining is chronically inflamed. Inflamed stomach is not something to be scared of initially, because anytime you eat something, guess what? Your stomach's going to become inflamed. Okay? But it's that chronic inflammation that's the problem. Your stomach is the only spot in your body that can absorb vitamin B12. And so we need that to make our red blood cells. So if we have chronic inflammation of our stomach, we can't absorb vitamin B12. It's going to lead to anemia. So we need to give cobalamin. Cobalamin is basically vitamin B12 injections. It's going to help treat pernicious anemia. Okay? Alright. Let's start talking about the meds, shall we? First up, we have H2 receptor blockers. Antihistamines. What other antihistamine we talked about? Benadryl, right? Antihistamine. This is a little different. There's different types of histamine receptors. Histamine receptors in your stomach actually are what kind of help produce stomach acid. Okay? So if we block those H2 receptors, what's happening to your stomach acid content? It's going to go down. pH is going to rise. So it becomes less acidic. So these all end in tidine. Imidine, famotidine, famotidine, they all end in tidine. Okay. They work fast, usually about a half hour. Only lasts about 10 to 12 hours. So you gotta take it in the morning, breakfast, where you start to eat, and then probably again at night, depending on how bad your GERD is, right? Ideally, you should take it in the morning, should be good for the entire day. Cover all your meals, cover all your snacks, should be good. Benadryl can lead to what when we give Benadryl?
The CNS depression?
A little CNS depression, right? We get that with these as well. We get that kind of change on the stats. Can we get that CNS depression a little bit? You get a little somnolent, lethargic, dizzy. So it's something you kind of want to look out for.
I had a question. With the ranitidine, didn't they used to like give that to everybody when they were in the ICU because of all the beeping noises, and then they quit doing it because of the pneumonia risk?
No, generally, well, wasn't until the beeping it's because they do stress ulceration, they do PPI instead. Because it lasts longer.
Okay.
You get Botanics once a day. So the other thing is you're decreasing acidic content of your mucus production in your stomach. Okay? Where else do you have mucus in your body? I think you're right. So what's attached to your throat? If you have mucus in your throat, where'd it come from? You probably coughed it up somewhere, right?
Yes.
From your lungs, right? So the mucus in your lungs also is slightly acidic. You don't have bacteria going in your lungs, right? So these H receptor blockers can potentially decrease the or increase the pH in your lung mucus as well, which would make you inclined for an increased risk of pneumonia. Okay. You also need some blood disorders. You want to be aware of your blood counts to make sure they're not getting out of order, and then cardiac arrhythmias. There we go. So basically, you want to look for your irregular heart rate, right? So generally, you want to try to avoid other antacids because you want to decrease the acid too much, right? We want you to just decrease it enough that we're not going to have a problem, but not too much. When you decrease stomach acid too much, now you can get some sort of stomach infection, right? You want to have that stomach acid there because it's a dirty environment. We want it to be there kind of to help make things work well. So if we decrease the acid pH, we're going to promote bacterial colonization in the stomach and respiratory tract. Okay, so that's what we have to be careful of. That balance. So if your patient's now on ranitidine, how do you know it's working? How do we assess that? Huh? Okay.
And what's up? You having heartburn?
Basically, the pain symptoms are gone. Like they're not having less reflux. The reflux is still going to be there, right? We're not treating the reflux. We're treating what gets reflux. So the worsening pain and the stomach ulcers and that stuff, that's going to be gone. There'll be no signs of an active GI bleed. The ulcer is going to be able to heal and then get treated. So we want to monitor for the CBCs, right? Because it can lead to what? Blood level changes. So we have risk for infection. We want to monitor those levels. We want to take it with food in the morning or at bedtime after lying down. Okay, if they're really bad, they can actually go to sleep. We want to be aware of that CNS depression. Who's going to be at increased risk of dizziness? All the people, right? So then the kidneys, what do you want to watch for? EO and creatinine, right? So if they have kidney injury, what are they at risk for with this? What's going to happen potentially? It's going to build up in the system, right? We said it has those CNS depression changes with it. If they have an acute kidney injury, it's going to be increased. So here's Zantac and Tegment, the tag team champions. They're beating up duodenal ulcers and burning gastroesophageal reflux. Good times. All right. TPS. Proton pump inhibitors. They'll end in cortisol. Not to be confused with other medications that end in azole. What ones ended in azole? Covered them last week. Antifungals, right? So something to be careful of. Just don't look for see one suffix and think that's it. Look for the whole root. Alright, okay, basically what it says is going to block that proton pump in the stomach, thus decreasing stomach acid production. Okay. When you choose receptor blockers, kind of start in a half hour and last 10 to 12. PPIs generally last up to 24 hours. They're not as quick of an onset, but they last longer. So they give more control. Okay? So if you have serious reflux, or if you have an ulcer, would you want to give a PPI or a receptor blocker?
PPI.
You want to get a PPI, right? Because it's going to give you that longer control and help keep the symptoms in check. So let's look at our. So we have some headache, abdominal pain, diarrhea, constipation. A little bit of insomnia, so this one gets a little bit of CNS depression. We can affect our vitamin B12 levels, right? That's where we absorb it in our GI tract, in our stomach. So it might still lead to a little bit of that pernicious anemia. So you gotta be careful of that and monitor that. We're gonna want to monitor the signs of that GI leak. So photosensitivity, wear sunscreen, glasses, and a hat. The main thing I want you to kind of get from this slide is this right here. For H. pylori. H. pylori is a very common gastrointestinal infection. Okay. It can lead to GERD and ulcerations. So if we're going to try and treat a stomach disorder, it's probably something that has longer control, right? So you're going to use that PPI versus the H2 receptor blocker. The bacterial infection. So we want to use 2 antibiotics. Notice how they are labeled for you: amoxicillin and erythromycin. So this is an H. pylori question on the test. You're going to think a PPI plus amoxicillin and erythromycin.
So 2.
Mm-hmm.
Amoxicillin and.
Yes. Both of them. Okay. We want to monitor B1 creatinine, right? Monitor kidney levels. We want to monitor uric acid and liver enzymes. Liver enzymes, ALT, AST. Uric acid should be 2 to 7. What other medications increase uric acid levels?
Gout? No.
That would help decrease. Covered 2 of them last week. They treated TB.
That will increase uric acid.
Mm-hmm. What meds do we use to treat tuberculosis? No, that's tuberculosis, so that's antibiotics. INH and Rifampin, right? Both of them together lead to an increase your gas level. What other medications lead to an increase your gas level? We covered them in cardiac. They work on your kidneys. Your gas levels. They cause you to go pee.
Diuretics.
Diuretics. All of those things increase your gas levels. Okay? Things you remember.
They decrease, you said, right?
Increase.
They increase.
Yep, increase. diuretics, iron H, and rifampin. Yeah.
Rifampin.
Yeah. I got giant ears, you can hear everything. Alright, so we talked about how we can decrease production of stomach acid. Now also about how we can protect the stomach from itself. So we know there should be mucus in the stomach protecting things, right? So if we have an ulcer, here's citrate or carfate. Basically, it's a lozenge. There's a little tablet. You suck on it. It kind of gets this little chalky, mucus, slimy texture. It makes mucus in your stomach. So it helps your stomach with a protective layer in your stomach, right? So you decrease stomach acid. Now let's put another protective layer in the stomach. Let's help protect it. So it does not do anything to your body, really. It does not get absorbed in the bloodstream, right? So it sits in your stomach, sits in your giant donut hole, working its way through. The only problem is you have this now these thick kind of gelatinous mucus in your GI tract. You have a risk of constipation. Okay. You might have a risk of decreased absorption of other medications because you got that thick kind of mucousy garbage going through your GI tract. So how do we, best way to prevent constipation? What do we do?
Increase fluids.
Push fluids and
So something.
maybe fiber, so softener set. The two F's. Fluids and fiber. Eat running oatmeal. Okay. Next up we have misoprostol. This one's gonna help stop the stomach acid, but also increase the mucus in the body. So it kind of goes hand in hand. It goes both mechanisms. Decrease stomach acid while also increasing the mucus. And increases bicarbonate. What is bicarbonate? That's your alkaline buffer, right? It's your anti-acidic buffer. Problem is, this can't be used for anyone who's pregnant. Misoprostol will induce labor. It can be used to actually help expel urine if you gave birth and 5% of the still left in the uterine lining. You pop a little tablet of misoprostol. I'll get that out of there. So if you are pregnant or potentially becoming pregnant or didn't know you're pregnant, it will induce contractions and we go into labor. Okay. That is the only adverse effect. Let's do. Okay. Another protective medication, Pepto-Bismol, Bismuth. So this is going to basically, again, going to help coat the stomach itself, right? It's going to help neutralize the acid and help coat the stomach from the acid. And it's kind of a thick material. Everyone's talking. Thank you for not talking. I'm not looking at anyone, so I don't want you to know I saw you talking, so I knew you were. So with Pepto-Bismol, it's that kind of chalky solution again, so you can kind of potentially bind up your GI tract, leading to constipation. High levels of this can lead to liver damage. You don't want to sit there chugging the pink stuff, right? You want to chug in moderation. It can also turn stool, bodily fluids, and tongue a dark brown color. Any mucous membrane, any buccal membrane, anything like that can turn brown. Okay? Give too much can lead to Ray's syndrome. What else causes that? Aspirin. Now I'll talk about antacids. Antacids don't decrease stomach acid production, right? They neutralize what is there. So it's very short term, short acting. They're aluminum, magnesium, sodium bicarbonate, and calcium carbonate. Okay. Aluminum and calcium products are going to lead to constipation. Calcium products risk for kidney stones with hypercalcemia. Sodium products, fluid retention. Magnesium, magnesia, makes the poop, diarrhea. Cardiac arrhythmias, we take too much. So, aluminum, calcium, constipation. Calcium by itself, constipation with kidney stones. Sodium, fluid retention, magnesium, cardiac problems, and diarrhea. Remember, they're only temporary short-term relief. So if we're giving an antacid, we're going to directly affect the absorption of other medications, right? So we want to give other medications 1 hour before or 2 hours after. That golden rule, right? So it's going to affect the absorption. Sodium products, heart failure, not good. We don't want to be on these for a prolonged period of time. If you're requiring antacids for a long time, are you treating the problem?
No.
No, you're covering the problem with some potentially could be overly misused medications. Could be taking too much. So if they don't get any better, talk to your doctor. Get on an actual H-Lister or PPI, right? Use something to actually treat the problem, not just covering it up. Next up, we have simethicone for GI bloating and GI bloating and gas, right? You went down to the Mexican restaurant on the street, got the frijole plate, that's with beans and cheese, right? Basically, at the time, now you get more gas that makes these days parade balloon.
Yep, that's when he knew he messed up.
So, what is this going to do? This is going to help relieve that gas, right? We want to try and give it before things happen, right? Before I get that frijole plate of cheese and beans, just take it beforehand. So it's already kind of working to help decrease the gas before it becomes prevalent. Avoid foods that are causing the trigger. If I know I drink a bunch of Coke full of CO2 and I get bloated, I should probably stop drinking Coke. Okay? So you're going to assess and make sure this comfort's getting better, right? The bloating's going down, you're having less gas, you're still having hypoactive bowel sounds. Alright. Vomiting. Everyone's favorite activity. Last week, one day, I got food poisoning. I was doing some of this. Some vomiting. It was not fun. I hate it. Terrible. But I knew it was a good thing. Right? Generally, why do you vomit? Generally, more of it's a protective measure. I had bacteria in my GI tract, right? You gotta get rid of it. I get rid of it, you get rid of it by throwing it up. Or up the other end. That's coming up. That's a couple slides later. Okay? So generally speaking, vomiting is going to be a protective measure. It can be induced by other things. So chronic cyclic vomiting is going to be bad. We're going to lose all our electrolytes, we're going to lose all of our acid, going to lead to fluid and electrolyte imbalance. Right? Acute vomiting, fine. Chronic cyclic vomiting, that's not good. Then you start to erode the stomach lining, erode your teeth, lead to ulcers, lead to bleeding. So we're trying to figure out what is the root cause of the vomiting. Fix that, fix your problem. We have a lot of anti-emetics. Emesis basically is vomiting, so anti-emesis, antiemetics, nausea medication. Let's go through these, shall we? Generally, we might use multiple antiemetics at lower doses to try and help treat the problem. Some of them work in a slightly different way, right? If you have chronic nausea and vomiting, we give you multiple medications at lower doses, give you better control for less risk of effects. Here is the first table of antiemetics. What do we have first? We have our serotonin FHT3 antagonist, or Zofran. Zofran is basically a serotonin antagonist. Okay? Where do we have a lot of serotonin?
Brain.
In
Our brain.
your brain. All nausea and vomiting is triggered by your brain's like reflex mechanism. If you seem to press down the brain function a little bit, nausea goes away. So Zofran really works great for your generalized types of nausea and vomiting. It's kind of the go-to. We're affecting serotonin, right? So what drugs should we probably avoid?
SSRIs.
SSRIs, right? Other serotonin medications. For risk of having serotonin syndrome. Serotonin syndrome presented with some nausea and vomiting along with hypertension, right? This is the telltale drug we give for nausea and vomiting. Which is why it's important when you go into when you have a new patient, you ask them what medications they're on, so you know not to give this if they're on the SSRI. How does you get your kidney liver damage and some decisions? So it's kind of the same kind of cardiac complications with your SSRI. Next up, we have our dopamine antagonists. Compazine, or Phenergan. So these work on dopamine receptors in your brain. So they're basically CNS depressants. When I had surgery last summer for my GERD, I got out of surgery, it's in the PACU, and the nurse goes, "You have any nausea?" I'm like, "Oh yeah, I just got, So the nurse is like, "Yeah, a little bit." She's like, "Okay." I don't remember anything for 2 hours. Give me Compazine, I was out. Because it leads to that drowsiness and seeing that depression. You can't be nauseous if you're barely awake, right? If you're tired and sleepy and drowsy, you don't know you're nauseous. So you calm it down and decrease things. But now what are we affecting? We're affecting dopamine. When did we treat dopamine previously in the class? Parkinson's, right? Levodopa, carbidopa, Cinemat led to the EPS symptoms. So chronic use of compazine can lead to those EPS symptoms. That tardive dyskinesia, those muscle tics. NMS, neurologic blindness syndrome, fever and hypertension. Next, remember pro-kinetics or pro-motility regolate. Pro-kinetic, pro-movement. Basically, it's going to increase GI motility, kind of help the GI system calm down a little bit. If your stomach feels overworked, let's get rid of stuff on the stomach to kind of help calm it down. We see some common things with dopamine with this one. Drowsiness, CNS depression. Okay. EPS. So they both kind of